We are live now, doctor.
Okay. So, good evening, postgraduates, and my namaskar to all the mentors. Welcome to this Pan India Intercollegiate Quiz Brain Teasers, which is being presented by Brain Teaser team in association with Ophthalmological Society of Nagpur, and that's Big Q for you. So, this is your famous signature tune, which must be used to last
अरे
7
इतना ही
seconds.
है।
अब तू अपने दम पर फूक मार के धूल झाड़ ले छोड़ छाड़ के सारे छप्पर हट समंदर अपना अंबर खोज ले अब तू अपने दम पर फूक मार के धूल झाड़ ले छोड़ छाड़ के सारे छप्पर खोल दे पर खोल दे पर खोल दे पर खोल दे पर बंद घड़ी की भी रुकी हुई सुई होती सही दो दफा चुप क्यों है रहना मन का तू कहना रोके चाहे हिचकियां खोल पर खोल पर खोल पर
So, thank you and welcome once more, postgraduates, for this program. This is the preliminary round. This is seventh season on behalf of Brain Teasers of the Big Q, which is in fact a dedicated quiz for all India postgraduate. And this quiz was initiated with a single thought of getting all across country multiple postgraduates on a single platform to help them in a better learning process as well. So now this time this is the preliminary round, and once we complete the preliminary rounds, we will be having 4 quarterfinals followed by 2 semifinals and the finalist. The best top 4 performance of the preliminary rounds will be considered for your entry into the quarterfinals. Now, without much ado, I would request Dr. Shilpi to familiarize you with the rules of the game and also to introduce all the quiz masters for today's show. Over to you, Shilpi.
Yeah, thank you, sir. So, welcome, postgraduates and all the mentors. Good evening. So, these are the quiz masters for today's episode, Dr. S. Venipriya ma'am, Dr. Prafulla sir, and Dr. Soumya ma'am.
Hello.
Hi, sir. Welcome, sir. So, let's see. I know you all are familiar with the format of the quiz, but let's quickly see what are the rules. So, in total, we have 6 preliminary rounds. Today is the 5th episode, and the criteria for qualifying for the quarterfinal is the best 4 performances out of the 6 preliminary rounds. So you have to log in through 2 devices, one for the Kahoot platform and the second one is the Zoom platform where the live quizzing will happen. So from the Kahoot, you will have to answer the questions which will be asked in today's episode. I request all the mentors to log in from separate screen only on the Zoom platform. So today we'll have 6 sets of MCQs. Each set will have 5 questions. You will get 10 seconds time per question and there will be no negative marking. So these are the prizes for the postgraduates in the finals. While for the audience, we have prizes per episode. But just to declare that for today's episode, we will be declaring the private practitioner category winners in the next episode and not today. So without wasting the time, I'll introduce our first quiz master, Dr. S. Venipriya. She is Associate Professor at Department of Ophthalmology, PIMS. She has 14 years of teaching experience in various medical colleges. She is executive member of various societies and presented various papers in state and national conferences. She has to her credit many publications in national and international journals, and most important is she published the Triple O book. With this, I hand over the screen to Dr. Venipriya. Welcome, ma'am.
Thank you, Dr. Shilpi, for the kind introduction. Good evening, everyone. So our first session starts. First question is, a patient presented with difference in eye color after installation of anti-glaucoma medication. What is the other side effect encountered with this drug? Option A, hypokalemia. Option B, macular edema. Option C, retinal detachment. Option D, iris cyst. And your time starts now. So the answer is macular edema, and the drug is prostaglandin analog. Actually, the prostaglandin analog, it does not increase the number of melanocytes. It just stimulates the melanogenesis, and it is not a risk factor for melanoma, and it accentuates the transcription of the tyrosinase gene. And there is iris discoloration with the prolonged usage in few patients. Other side effects include macular edema, conjunctival hyperemia, uveitis, herpes keratitis, reactivation. Next question. A patient came to OPD with a defective field vision more inferiorly, which progressed clockwise in the left eye and anti-clockwise in the right eye. The most probable diagnosis being option A, pituitary adenoma, option B, CP angle tumor, option C, craniopharyngioma, and option D, atypical optic neuritis. And your time starts now. And the answer is craniopharyngioma. Obviously, the inferior, it's denser in the inferior field. So something is compressing from the above. The optic chiasma is compressed from the above. Craniopharyngioma is the one which compresses from above. So the inferior field defect happens. The superior fibers will be affected. Inferior field defect happens. And the pituitary adenoma compresses the optic chiasma from below. So the inferior fibers are lost first. So the superior field defect happens. Next question, please. Mitomycin C is an anti-neoplastic antibiotic isolated from option A, Streptomyces parasiticius, option B, Streptomyces cespitosus, option C, Streptomyces mediterraneae, and option D, Streptomyces mabarensis. And your time starts now. And the answer is option B, Streptomyces cespitosus. It is a factual question. It is an antibiotic chemotherapeutic agent, and it inhibits the DNA synthesis. The dosage used, normal dosage used is 0.2 milligram per ml for 2 minutes, and the concentration can be 0.02 to 0.04 percentage. Indicated commonly in glaucoma filtering surgeries, pterygium surgery to prevent the recurrence, refractive surgeries, ocular surface tumors, squint surgeries, and dacryocysto-rhinostomy. Next question, please. All studies mentioned below involved treatment versus no treatment in glaucoma except option A, OHTS, option B, AGIS, option C, EMGT, and option D, CNTTS. And your time starts now. And the answer is AGIS, that is Advanced Glaucoma Intervention Study. It is a multi-center randomized clinical trial which compared the two sequences of surgical treatment for advanced glaucoma. Organ laser followed by trabeculectomy, followed by second trabeculectomy versus trabeculectomy, organ trabeculoplasty, and trabeculectomy. And they found out ATT sequence had a better preserved vision for black patients because of the pigmented trabecular measure, while the TAT sequence was superior for white patients. Next question, please. Which of the following intraocular lenses is most likely to prevent posterior capsular opacification? Option A, sharp-edged hydrophobic acrylic IOL placed in the capsular bag. Option B, sharp-edged hydrophilic IOL placed in the capsular bag. Option C, sharp-edged PMMA IOL placed in the capsular bag. Option D, sharp-edged silicone IOL placed in the capsular bag. And your answer is, and your time starts now. And the answer is option A, sharp-edged hydrophobic acrylic IOL placed in the capsular bag. So the truncated edge prevents as a mechanical barrier to epithelial cell migration across the posterior capsule when the lens edge is in direct contact with the posterior capsule. Next question, please. So I'm very much excited to introduce our next quiz master, Prafula Kumar Maharana, who is the additional professor, RP Center, AIMS, New Delhi, and secretary of Delhi Ophthalmological Society. He is a proficient scientist with H index of more than 30 and 50 chapters. He has published more than 50 chapters in national and international books. And he has won Best Surgical Technique Awards from Ransco, Australia, and awards for best paper in various conferences. And he is a principal investigator in 2 ICMR trial, co-PI in 18 trials, including 2 multicentric international. And he is a mentor in women scientists for DBT projects, editor of 3 Amazon bestsellers in ophthalmology, editor The Ars Times and 40. And he is among one of the topmost cornea surgeon in the world. Welcome, sir.
Thank you, Dr. Venipriya, for that kind introduction. Am I audible?
Yes, sir. Yes, sir.
Okay, so welcome all the PGs here. So we'll have a section 2 and my specialty is cornea. So of course, all the questions will be from cornea. So can we go ahead, Shilpi? Yes, so in the new ABCD system for classification of keratoconus, what does B stands for? So the options are A, is it the posterior radius of curvature in the 3 mm zone centered on the thinnest location of cornea? B, is it the posterior radius of curvature in the 3 mm zone centered on the vertex of the cornea? C, is it the posterior radius of curvature that is centered on the anatomical center of the cornea? So it's basically the center. D is back elevation on pachymetry map. So you have to decide which is the right answer. Yes, timer, please. Okay, can we have the answer? Okay, so it's basically located on based on the center of the thinnest location of the cornea, not the vertex or not the anatomical center. Let's move on to the next topic. Next question, sorry. Yes, so early onset FECD, fused corneal endothelial dystrophy, is associated with mutations of what? Option A, is it the COL8A2? I hope you know this stands for collagen 8 alpha 2. B, TCF4. C, option C is SLC 4A11, and D is LOX HD1. So which is the right answer? Timer. Okay, so what's the answer? The answer is A. Okay, so the only option which I elaborated, that was the clue. So that is the right answer. Let's move on to the next question. Okay, so a mutation in TGF beta 1 gene, predominantly arginine replacing tryptophan at position 555, will result in. So we all know this as a big A gene earlier. So the option A, will it lead to avelinocorneal dystrophy? Option B, will it cause granular dystrophy type 1? Option C, lattice corneal dystrophy type 1. Option D, plaque corneal dystrophy. So timer, please. TGF beta 1 can lead to a lot of dystrophy. Be careful about the position. Position 555. Okay. Answer, please. So it can lead to granular corneal dystrophy type 1. So this single mutation, depending on where the exact location is, it can lead to a lot of dystrophies. You know, there is a mnemonic, you can remember that, GLARE, GLARE. G for granular dystrophy, B for lattice corneal dystrophy, but not type 1, A for Avellino, R for Reese Buckler. Okay, so these 4 dystrophy can be associated with TGF beta 1. But ARG555, TRP each specific to type 1 granular dystrophy. Okay, let's have the next question. So varenicline nasal spray in dry eye acts through. So this is the newest drug, newest no, maybe 2 years back. So how does it act? A, by acting on the cholinergic receptors. Option B, by acting on the aquaporin receptor. Option C, it's a purinergic receptor which is responsible for. Or D, it's a toll-like receptor. So when you use this spray, how does it increases the tear secretion? So timer, please. Okay, so what is the right answer? So it acts via the cholinergic receptors. Okay, it stimulates those receptors, and cholinergic pathway is responsible for increased tear secretion. Let's move on to the next question. Okay, this is the last question of this segment, I guess. So lifitegrast, which is the recently launched drug, acts by what mechanism? Option A, it binds to the LFA1 and inhibits it from interacting with its ligand, which is ICAM1. Option B, it binds to ICAM1 directly and inhibits T lymphocyte. Option C, it binds to LFA1 and inhibits from interacting with its ligand, which is ICAM2. So between A and C, only 1 and 2 is the difference. Option D, binds to LFA1 and inhibits T cell. So how does it act in cases of dry eye? Timer, please. Okay, so what is the right answer? Okay, so it binds to LFA1 and inhibits from interaction. So it's basically a competitive inhibitor. It binds and then compete for the ICAM1 binding site. Okay, I think we are done with the first segment, and it gives me immense pleasure to invite your next quiz master, which is Dr. Soumya HB. So Dr. Soumya HB has done her MS ophthalmology from Government Medical College, Mysuru. She has done her fellowship in medical retina from Retina Institute of Karnataka. She has done an advanced course in medical education from St. John's Medical College. Currently, she is working as professor and head of the department of ophthalmology of JSS Medical College and Hospital, Mysuru, Karnataka. And she is the recipient of many awards, including AI's National Resource Teacher Award for Guru Sangam Medicine 2024-25. And she is an invited faculty in many state and national conferences. And I'm sure we'll invite for DOS also, and ma'am will joining us for our annual conference. Welcome, ma'am.
Thank you so much, sir. Thank you for your kind introduction and invitation too. Thank you so much, Dr. Prafulla, sir. And thank you, the Big Q team, for this great opportunity to be on this platform. Can we have our set of questions, please? Am I
Yes.
audible?
Can you be a little closer to the mic, please?
Am I audible now?
Yes, ma'am.
The question number one, bilateral pulverulent disc-like opacities involving the embryonal and fetal nucleus with tiny white dots in the lamellar portion of the lens is known as option A, zonular cataract, option B, cerulean cataract, option C, Christmas tree cataract, and option D, Kopak cataract. And the time starts now. And the answer is Kopak cataract. So these Kopak-like cataracts consist of bilateral progressive opacities of the embryonic lens nucleus. So they have a pulverulent opacification with a grey disc appearance. The visual symptoms often begin during adolescence, and some patients may require surgery by the 5th decade of life. Next question, please. The radiographic feature which is considered pathognomonic for optic nerve sheath meningioma is option A, adjacent bony erosion, option B, kinking of the optic nerve, option C, multiple cystic cavities within the optic nerve, and option D, tram track enlargement of the optic nerve. And your time starts now. Can we have the answer, please? And the answer is, of course, it's a tram track enlargement of the optic nerve. Many signs on radiographic features are noted, but the classic is the tram tracking of the optic nerve for optic nerve sheath meningioma. The next question, please. The OCT parameter that correlates best with visual function in retinal vein occlusions is option A, central macular thickness, option B, integrity of ellipsoid zone, option C, presence of SRF, and option D, size of cystoid spaces. And your time starts now. And the answer is the integrity of ellipsoid zone. The SCORE 2 trial analyzed it was one of the largest prospective data sets. So it said that both qualitative and quantitative assessments of ellipsoid zone integrity, they said that they are the robust predictors of visual acuity in retinal vein occlusions. So without any ellipsoid zone defects, they had consistently better visual acuity letter scores. So larger areas of the ellipsoid zone loss were associated with worse visual outcomes across multiple time points over 24 months. The next question, please. Bilateral elongated radiating drusen in the macula are characteristic of option A, Best disease, option B, Malatia levantinis, option C, Stargardt's disease, and option D, Sorsby macular dystrophy. And the time starts now. And the answer is Malatia levantinis, so which is also known as the Doyne's honeycomb dystrophy. So this is characterized by elongated radiating drusen in the macula. So they may extend beyond the arcade, even peripapillary areas also they may be seen. So some patients may develop CNVM in these disease conditions. The next question, please. The last question. A 15-year-old girl presented with acute onset bilateral non-granulomatous anterior uveitis as suggested in this image. She also had features of renal failure. The most important test to make a definite diagnosis is option A, beta 2 microglobulin detection in the urine and serum, option B, proteinuria, option C, renal biopsy, and option D, HLA typing. Your time starts now. And the answer is renal biopsy. So this condition is tubulointerstitial nephritis and uveitis. Even though all these are important for diagnosis, the gold standard is with renal biopsy. So they may have vague symptoms, they may have fever, malaise, fatigue and flank pain. Beta 2 detection, microglobulin detection in the urine and serum, presence of proteinuria, eosinophils are there, but the most important diagnosis, the gold standard, can only be made with renal biopsy. That brings us to the end of this session. Thank you so much.
Thank you, ma'am. So, with this, we are over with the three sets of MCQs and three are remaining, and it's a time for short commercial break. We thank the His Highness team for all the financial support for this season. So, our next episode will be on 18th of February at same time with three new quiz masters. So just mark the date and time. So now we move to the next section. I again request Dr. Veni Priya ma'am to please continue.
So, welcome back to the second session. The question number 6 in between. So, identify the personality. Option A, Hans Goldman. Option B, Jules Gonin. Option C, Sir Harold Ridley. And option D, Charles Kellman. And your time starts now. And the answer is option B, Jules Gonin. And he is the father of the RD surgery, and he introduced the ignipuncture, which is the forerunner of our barrage lasers. And he is the one who told that hole was the cause of RD, not the consequence. Next question, please. So identify the condition by seeing the picture. Option A, advanced retraction syndrome. Option B, Brown syndrome. Option C, Grabnigo syndrome. Option D, Bonat syndrome. And your time starts now.
Madam, don't declare the result for a moment. 1 minute. Yeah, you can go ahead now.
Requesting everyone to please mute except Dr. Veni Priya.
The answer is option B, Brown syndrome. So it is a vertical strabismus, and it resembles superior oblique palsy, but the limitation of elevation is due to the abnormality in the superior oblique tendon and trochlear complex. Next question, please. A 35-year-old patient presents with vertical diplopia, which worsens while reading and going downstairs. He adopts a compensated head tilt to the right. Ocular movements are shown in the figure. And in part 3 step test, in step 1, which eye is hypertropic in the primary position? Option A, right eye. Option B, left eye. Option C, both eyes. Option D, cannot be determined. And your time starts now. And the option answer is B, left eye. So it is a superior oblique palsy. Head tilt is away from the side of the SO palsy. So here the patient had right head tilt. So it is left superior oblique palsy. So in the first step where we see the which eye is hypertrophic, the left eye will be hypertrophic. And the mnemonic for the next 2 steps are worsens on the opposite gaze, that is wood, and better on opposite tilt. Next question, please. Pachychoroid spectrum includes all except A, retinal angiomatous proliferance, B, polypoidal choroidal vasculopathy, C, central serous chorioretinopathy, D, pachychoroid neovasculopathy. And your time starts now. And the answer is option A, retinal angiomatosis proliferans. Pachychoroid spectrum is a group of macular disorder which has a common feature of thick choroid, dilated and hyperpermeable choroidal vessels, and attenuation of choriocapillaries and RPE dysfunction. So it has 5 diseases under the spectrum: polypoidal choroidal vasculopathy, central serous chorioretinopathy, pachychoroid neovasculopathy, pachychoroid pigment epitheliopathy, and peripapillary pachychoroid syndrome. RAP is a feature of the retina, so it doesn't come under pachychoroid spectrum. Next question, please. So this is a OCT picture showing findings. Which of the following statement is true regarding this condition shown in the pic? Option A, it represents active choroidal neovascularization requiring immediate anti-VEGF therapy. Option B, it is a sign of irreversible photoreceptor rearrangement and does not indicate disease activity. Option C, it corresponds to intraretinal cystoid spaces seen in diabetic retinal and diabetic macular edema. And D, it is typically associated with thick choroid and pachy vessels. And your time starts now. And the answer is, it is a sign of irreversible photoreceptor rearrangement and does not indicate the disease activity. These are outer retinal tubulations. So the degenerating photoreceptors aggregated into tubular structures that appears as a roundish hyporeflective spaces. It doesn't represent the SRF or the fluid accumulation. It causes usually age-related macular degeneration, and it is usually mistaken for intraretinal fluid, prompting initiation of unnecessary treatment. In neovascular ARMT, if ORT is present, it indicates poor visual prognosis. If it is seen in geographical atrophy, it displays that there can be a slower enlargement of the atrophic.
I think connection is lost. So I invite Dr. Prafulla sir for the next section.
Yeah, welcome back, everyone. So I'll be continuing with another set of cornea questions. So can we have the questions here? Okay, so acetylcysteine, it's a mucolytic agent. You all know it's given in filamentary keratitis. So how does it act? Option A, it acts by breaking down the mucus and reducing its viscosity. Option B, it acts by causing epithelial cell lysis and less filament formation. Option C, it acts by supplementing the mucin and glycocalyx layer of teofilm. Option D, it acts by anti-adhesive mechanism. So your timer starts now. Okay, so the answer is option A. Okay, so basically your these filaments, they consist of your epithelial cells and mucus. Okay, so it acts by breaking down that mucus and reducing its viscosity so that the filaments are not formed. Okay, let's move on to the next question. Okay, which of the following antibiotics are best for treating Pythium keratitis? Okay, as per the latest guideline. Okay, so options A, the linezolid plus azithromycin. Option B is linezolid with miltefosine. Option C is mucolide plus azithromycin. Option D is miltefosine and linezolid. So it's just the flip of option B. Okay, so your timer starts now. I think I have made this easy for you, no? Between A or C. Okay, so what's the right answer? Okay, so it's a combination of linezolid and azithromycin. That is the standard. Earlier, we were using a lot of drugs. Miltefosine is useful, but it's very toxic. So now it's almost accepted that the ideal treatment is start with linezolid and azithromycin. Let's move on to the next question. Okay, perfluorohexyl eye drops works in meibomian gland dysfunction by. So how does it act? Okay, so option A, it supplements the mucus layer. Option B, it stabilizes the glycocalyx layer. Option C, it reduces evaporation. Option D, it acts by mechanical protection from the lead movement. So this is the recently approved drug. You must have heard of it. So how does it act? Timer, please. Okay, so the right choice was, so it was reducing evaporation. Remember, this is the only drug, as the marketing team claims, is the only drug that has been approved for evaporative type of dry eye. Okay, so next question. So Ulcus serpens, okay, so MBBS question, you all know it. It's a type of hypopen ulcer, so we know it. So which organism causes it? Option A, Streptococcus pneumoniae. Option B, Pseudomonas aeruginosa. Option C, Nocardia. Option D, actinomycetes. Okay, so your timer starts now. It's a characteristic ulcer. As the name suggests, it's just like a snake. Ulcus serpens. Okay, so what is the right answer? So right answer is option A. Yes, Streptococcus pneumoniae. So pneumococcus spread like this, and that the ulcer is characteristically known as ulcus serpens. Next question. So this is the last question of this segment. The average thickness of a normal DMAC graft is option A. Is it 5 micron? Option B. Is it 15 micron? Option C. Is it 45 micron? Option D. Is it 95 micron? So what is the average thickness of a DMAC graft? So timer starts now. Okay, so what is the right answer? So the right answer is 15 micron. Basically a normal DMAC graft means it's a descemet membrane. Okay, the descemet membrane thickness ranges between somewhere around 12 to 15 micron. So the best answer in this is 15 micron to go for. With this, I'll conclude here. Next, I would like to invite Dr. Soumya for her session, her segment.
Thank you so much and welcome back to another set of questions. Can we have the questions, please? The first question, which of the following ocular motor disorders is most associated with malignancy? The options are option A, square wave jerks, option B, ocular flutter, option C, opsoclonus, and option D, ocular bobbing. And your time starts now. And the answer is opsoclonus. Opsoclonus are non-stop, random, directionally unpredictable saccades. So flutters is nothing but spontaneous group of back and forth horizontal saccades. So both ocular flutter and opsoclonus may be associated, but the common movement that is associated with malignancy like metastatic neuroblastoma or small cell cancer is opsoclonus. The next question, please. Preserved visual acuity with early contrast sensitivity loss in papilledema is due to preferential involvement of option A, foveal cones, option B, parvocellular pathways, option C, magnocellular pathways, and option D, retinal pigment epithelium. Your time starts now. And the answer for this question is magnocellular pathways. So these pathways are one of the earliest um, involvement or earliest things that could get involved in papilledema. The next question, please. Image jump is most troublesome for bifocals of the option A, fused type, option B, round top type, option C, flat top type, and option D, ribbon type. And the time starts now. And the answer is round top type. So image jump usually occurs at the segmentation line when the optical center of the ad is not correctly in the upper edge. So round top bifocal segment in a spectacle has the optical center farther from the upper edge. So therefore causes the greatest image jump. The next question. The most accurate statement that describes this condition is option A. This is the most common form of Langerhans cell histiocytosis. Option B. Incidence is more in adults than in children. Option C. Presence of multinucleated giant cells is more specific to this condition. And option D. Spontaneous hyphema is one of the causes for secondary glaucoma. And the time starts now. And the answer for this question is Spontaneous hyphema is one of the causes for secondary glaucoma. So this is a juvenile xanthogranuloma. This is more commonly seen in children than in adults. It's one of the rarest forms of Langerhans histiocytosis. So Tauten's giant cells are not more specific to this condition. That the correct answer would be spontaneous hyphema, one of the causes for secondary glaucoma. The next question. The histopathologic variety of meningioma that is most commonly seen within the orbit is option A, angioblastic, option B, transitional, option C, meningothelial, and option D is fibroblastic. And your time starts now. And the answer for this question is meningothelial. So this is one of the most common histopathologic type of meningioma seen within the orbit, and this was the last question of the session, and this completes the session. Thank you so much.
Thank you, Soumya ma'am, Venipriya ma'am, and Prafulla sir. So with this, we end the today's quiz. So
Thank you, Shilpi, for all the hard work you have done. And thank you, Bhavan Kule sir. In spite of his busy schedule, he still takes out time and do this brain teaser. And all credits go to sir. And thank you for both the quiz master. And I've already invited Dr. Soumya. I would like to invite Dr. Venipriya also to our annual DOS conference, if he can join us. And good night, everyone.
Thank you.
I
Thank you,
want to
ma'am.
acknowledge Dr. Annapurna ma'am. She is the one who helps me out with all the back end work and everything. Size, ma'am is there.
Let me check, madam.
Thank you so much for the opportunity, Dr. Shilpi and Prashant sir. And it was very nice to have Dr. Prafulla sir and Dr. Veni madam as co-quiz masters, and really enjoyed the quiz. Thank you so much for the opportunity, and thank you for the invitation, sir.
Do you also
Thank you,
have any?
ma'am, and convey my thanks to sir also. Thank you, Soumya ma'am and Prafulla sir.
Sai, do we have any mentors with us? I can see.
Nobody's raised their hands yet, madam.
Okay. Okay. So we will be meeting after 2 weeks. That is, it will be on 18th of February at same time. And this episode's private practitioner winners we will be declaring in the next episode. So once again, thank you all the quiz masters, participants, all the mentors and postgraduates for joining for today's quiz. So see you all after 2 weeks at the same time. Thank you, Praful sir. Thank you, ma'am. Thank you, Venipriya ma'am.
Thank you.
Good night, everyone.
Good
Thank
night.
you and good night, sir. Thank you so much.